decided that the opening ceremony will be very formal. However, after the opening ceremony, it's informal. So I advise everyone and encourage everyone to come. If you're wearing a tie, get rid of it. If you're wearing a jacket, get rid of it. Starting tomorrow, if you want to come, not tomorrow, today, if you want to come in a t-shirt, in jeans, in your thobe with a cap, please feel free. And feel free to interact. The meeting is mainly sessions that are interactive. I know that sometimes the lectures are a bit too long, relatively, but we have very good people with great experiences that we want to learn from them. And this is the reason that we gave them some extra minutes to explain at least some of their experiences. However, we encourage you to get involved in the discussion. What we care about really is the discussion. There will be people taking notes of what you say. There is a meeting that we will have on Friday morning. For those of you who are interested, we'll have 5 groups or 6 groups discussing different issues related to ophthalmology and development of ophthalmology in Saudi Arabia mainly. And if you like to participate in these, please give your names to Dr. Deepak Edward or to Dr. Babar Qureshi over here. And otherwise, I encourage you, please, to get involved in the discussion. Thank you very much. Dr. Adil.
Shukran Abdulaziz. Assalamu alaikum. Well, I'd like to welcome everyone, and without any further delay, we'll start the first session after the opening ceremony session. It is titled Reaching Out, Nationally and Community Engagement. And our first presenter is Dr. Rao, and he is a well-known name in the international ophthalmology. And he's the chairman of LV Persad Eye Institute in India, in Hyderabad, India. They have an tremendous experience in the outreach work, and we'd like to share what he has with us. Thank you. Please, Dr. Rao.
My apologies for wearing a white shirt now. I think Aziz didn't tell me in the morning. Otherwise, I could have come in a t-shirt. So. At the outset, I'd like to offer my congratulations to all our friends at the King Khalid Eye Specialist Hospital for the celebration of their 35 years of outstanding work in the area of clinical care, education, research, outreach, and in the areas of advocacy and global leadership. What I'd like to share with you is an experience of ours over the past nearly 25 years. In addition to what we do at our main institutes, campuses at the tertiary level, I'm not going to talk about that at all. I'm going to only talk about what we do in the rural areas of India and the model we try to create and the experiences out of that model. I want to start with this video, if I can run this video. I don't know if Sorry? Can I do that? I don't know if I can. I don't know how to do that. Okay, that's fine. That's okay. No, in that video, what I was trying to show is a very moving experience of a son whose family lives in the remote rural areas of India, and an experience that is seen all over the world, everywhere, in every corner, of having to carry his mother in a basket and walk across a river which has no bridge in a perilous journey to get her access to health care. So what we try to do in our aspirations of universal health coverage throughout the world is to avoid such perilous journeys for anybody to access health care. It's an aspiration of every country from America to the poorest in the world. And India has joined this club about 6-7 years ago with a committee that was formed to provide universal health coverage to every Indian. We are a country of 1.3 billion people, a mammoth task to provide universal health coverage for such a large population. But just about a month ago, the Prime Minister has actually announced universal health coverage to the bottom 100 million families of India. That's about 500 million people, providing coverage for all secondary and tertiary levels of care, in addition to whatever services are provided at the primary level through the governmental system, to ensure equitable access for all citizens for affordable, accountable, and appropriate health services. But when we come to think of the problems, the challenges that we have many. Reaching the populations that are currently underserved, and to provide comprehensive care in the true sense. While we talk about it, hardly anybody practices comprehensive care. While at the same time making sure that we have good quality care. One major challenge that is rampant throughout the developing world is the challenge of not having adequately trained human resources of adequate numbers, and that needs to be addressed, and to also develop a sustainable infrastructure through a variety of partnerships. And of course, with this global era of technology, we have to try and leverage technology to the best possible way. So in our world, visual impairment and blindness remain a significant cause of disability. If we look at it, approximately 4 out of every 5 is needlessly impaired, either preventable or treatable with the already available knowledge, technology, and techniques. India has the largest magnitude of blindness. In fact, it has had the first national program ever for prevention of blindness for the past nearly 45 years. There's a fair degree of governmental commitment to eliminate blindness, reasonable infrastructure throughout the country. We have some good islands of excellence of training infrastructure and several models of very good eye care delivery, but that needs scaling up. In the most recent publications of the World Health Organizations and the Global Burden of Disease Group, it looks like we have about 8.5 million people blind and about 5 times that number with significant visual impairment. The predominant causes are very similar to what you see in most parts of the developing world. But what is important to understand from this list is that we have causes for which we have already effective and cost-effective public health solutions, and causes where we are still scrambling to find a solution. And the risk factors, as expected, more in women, lower socioeconomic groups, those who live in rural and distant areas with significant geographic disparity. So when we began to look at our developing a rural healthcare model for eye care, we asked ourselves the question, so how do we address this? And we wanted to look at the possibility of a vertical integrated model of eye care delivery that covers all segments from primary to advanced tertiary care of eye care. And one of the first things that we did was to embark on a large-scale epidemiologic study in collaboration at that time with the University of Melbourne, Hugh Taylor's group, called Andhra Pradesh IDC study. That gave us significant, reliable information on the problem of blindness, the magnitude, the causes, the barriers for accessing care, etc., as well as for visual impairment. And more or less corroborates with the causes that we have seen recently with the World Health Organization report. And out of this information, we have arrived at a pyramidal structure of delivery of eye care. 5 tiers, a primary care divided into 2 segments, a community-based primary care at the very bottom, next a center-based, then secondary, tertiary, and advanced tertiary. The idea is to aim for covering everybody in the segments, geographic segments that we serve, with comprehensive eye care that would encompass prevention programs, treatment, and rehabilitation. Commitment to quality, taking care as much closer to the doorstep of the people as possible, a continuity of care, so permanent facilities in remote rural and tribal areas, and active participation of the local communities in this. This we started for the first time around 1992. But then around 2000, the WHO came up with this nice definition of primary care, and we felt very happy. It more or less validated our approach. And that's how we evolved at the comprehensive care. It's comprehensive in terms of covering all the eye diseases that contribute to blindness, comprehensive in terms of geographical and population coverage, comprehensive in terms of the services that are provided, and appropriate linkages and referral systems. At the very bottom of the pyramid, we work with a population unit of 5,000 people. We work with what we call vision guardians. These are healthcare workers or volunteers or school teachers, somebody educated in that community, to whom we give a short-term 2-3 day training and then make them our representatives in the community. They help us in eye health promotion activities, screening, and making appropriate referrals, and also keep an eye on the people who have had some kind of intervention to make sure that they're going for post-operative follow-up care. And to keep an eye specifically on the 2 vulnerable age groups, the pediatric and the geriatric. And then, of course, participate in the community-based rehabilitation programs. More recently, through our Technology Innovation Center, we came up with this new thing called Folding for Opta, something that we are able to make for about $2 to $3 a piece. And this will be able to give you a simple device to screen and eliminate the possibility of refractive error. In 1 minute, it will tell you whether someone has a refractive error or not. And we are now planning to place this in the hands of every school teacher in 3 states that we are covering, and very often we are getting requests from all over the world now to get some of these phoropters for their usage. And it's a phenomenal. It has won many international awards already, and it's a very exciting development for us. At the next level, we call it center-based primary care, a concept of vision center that we came up with about 25 years ago, a center covering 50,000 population in remote, rural, and tribal areas where there is no semblance of healthcare at this point. A one-year trained vision technician selected from the local community and trained is placed there to staff these centers. And they are trained to provide refraction and dispensing services. And as you all know, uncorrected refractive error is the biggest problem of vision impairment of all, more than 50%. They will be able to handle all that. In addition, they will be also able to detect all potentially blinding diseases and then make appropriate referrals. And then linkage with other healthcare as well as linkage with the secondary level of care. 10 such centers are linked to a secondary level eye center where there is an ophthalmologist. So the concept is universal access, care in the remote communities of high quality, no requirement for an ophthalmologist because no ophthalmologist would like to go and live in those communities, high quality and part of a sustainable system. And the more recent version of vision centers, for the past 3-4 years, we have added significant technology components that have helped us to actually do teleconsultation, faster dispensing of glasses, and then more focused approach. And also we are now feeding all this into the big data system to be able to come up with many more future solutions, hopefully. And we are attaching what we call a Cyclops, again, an innovation from our Technology Innovation Center, which takes the pictures whenever there is a doubt for the vision technician and then moved up to the command center at the institute where an ophthalmologist looks at it and immediately gives the advice to the vision technician whether this patient needed any further referral up the chain system. One thing that made me very happy about a year ago was I went up to an island, the biggest river island in the world called Majuli in river Brahmaputra. It's in the northeastern part of India, bordering Bangladesh and China in that part. And that area, in the middle of that river, which has no access by road, you can only reach by boat, they created the first vision center serving that population of nearly 100,000 people. That made me very happy that this kind of model is beginning to work. At the next level is a service center, we call it generically. It's a secondary level service center where you have an ophthalmologist and a team of 25, 35 people and providing many services. All diagnosis and medical care, surgical care, predominantly cataract, and of course some glaucomas and all. But more recently, we have begun to incorporate more of the tertiary care at this level. Example is a corneal transplantation. A corneal surgeon, a member of our faculty from the tertiary center, travels there once a month, performs transplant. The eye bank at the center provides the corneas to them. And then the ophthalmologist, our ophthalmologist placed in the secondary center, can provide the follow-up care and also connected with the technology, can have always a consultation from the cornea faculty at the main institute. So we are using drone slit lamp as well as WhatsApp for a variety of consultations, and the ECHO platform that is developed by University of New Mexico to teach and constantly train our doctors in the rural centers. So we are also now beginning to look at complicated glaucoma, diabetic retinopathy, beginning to do pediatric care, advanced, etc. at these secondary centers. And between the secondary and primary centers, you have a variety of programs that are going on in the middle. Shown in blue here, screening programs of various kinds, children's programs, diabetic programs. So together, they will contribute to this whole thing. And finally, this is the complex that we are talking about, what we call a village vision complex, a secondary care center attached to 10 vision centers and 100 vision guardians, each one covering a population of 100 to 200, a million, 1,000 people. So this, if we apply properly with good infrastructure, well-trained team, can take care of 90% of the blindness. So when you take care closer to the people, more people access. One thing that we found was the gender disparity, the gender inequity is completely eliminated. 55% of all patients that access our services in these networks happen to be women. Thank you so much.
Thank you, Dr. Rao. The second presentation is by our friend from Bahrain. No, sorry. Our friend Dr. Saeed Al-Mutawwa, and he is a senior academic consultant and member of the anterior segment division at King Khalid Eye Specialist Hospital. He is going to tell us about the role of KKESH in national outreach. Dr. Saeed.
بسم الله الرحمن الرحيم. السلام عليكم. Good afternoon, everyone. Thank you very much, Dr. Adel, for introduction. I would like to thank Dr. Abdulaziz Rajhi and also the organizing committee for organizing such a meeting, which let us to see our all of you and our teachers and our previous friends. Also to put some highlights on the outreach. بنطلع هذه كاملة على العرض هنا عندي علشان أشوف. As you can see the map of Saudi Arabia, it is a huge country, and KKESH is always the shining spot for ophthalmology services. And as presented in the morning, the role of KKESH, it's not just only taking care of patient care, it's also taking care of patient care training, and we have the nice and very efficient product of KKESH training program, not only at the level of ophthalmologists, but also the other ancillary services and also research, which make KKESH the top of the International Institute for Research. Actually, this has been discussed by Dr. Abdulaziz Raj in the morning, and others will talk about it. My aim is to talk about the outreach. As you know, KKESH is a tertiary care center, and usually we have the tertiary care guidelines, and which gives priority for the patient just only who have the tertiary care and complicated cases. And whenever you refer patient, I'm sure all of you working in all the hospital in the kingdom, you might surprise patient was rejected and not accepted at KKESH because of the tertiary care guidelines, and and also all these things because of the tertiary care guidelines. And most of the peripheral hospital in the past mainly, they don't have the ophthalmology facility, and when patient rejected and not accepted at KKESH, I really felt sorry. Either to treat patient or to find a solution. And for that reason, we work for that over the last 15 years. And we try to find a solution for such problem. And what was our aim for outreach? The aim is to provide treatment to patient, all patients, and mainly those in the periphery to treat them in their own places, and also to improve the ophthalmology services. And this is another goal for the outreach, and for all the peripheral hospital, and to provide equal ophthalmology care with balanced all over the kingdom, not just only in central area or Riyadh area, and to minimize the cost of patient traveling and all the family disturbances, because this is either most of our patients, either children or old patients, and this will make a disturbance for the whole family. And this is very important to get benefit from our graduate, which is we have many graduate, and some of them, they will not have the facility, and they will try, they will struggle, then they will stop unless they are find another solution. And as I mentioned, always we have the tertiary guidelines in KKESH, and we update it in a yearly period. And acceptance of patients through the eligibility just only for those who's according to the criteria. And these criteria were updated from time every year. And most of private hospital past had limited resources. And this is an example. The tertiary guidelines, we are doing it on a yearly basis, and this is for the anterior segment and other specialty. We have the guidelines and the tertiary care, and we are trying to make it tighter every year because the improvement of the services and facility in the peripheral hospital. So we are trying to limit acceptance according to the criteria. And when I started the outreach, we thought this is not fair to reject patients and they don't have facility. So how can they be treated? And this is just only an example. You can see here the number of ophthalmologists and YAG and argon machine, and you can see the list of all hospitals in the kingdom. Then after that, so after collecting the data, I just send a report to the Supervisor General recommending to start outreach. And you can see it here to be as the start of the outreach, and it's well clear. And he welcomed the suggestion, and he sent it to for approval from the Ministry of Health, which was approved. And which was just took around 5 months, being approved from the Ministry of Health, and it was started June 2006. My colleague, Dr. Abdullah Tirbag, he started for about 1 year, then he moved to Qasim University. Then we started collecting data regarding ophthalmologists, even we assign in each province representative and coordinator. Coordinator from the administrative point of view, and representative as ophthalmologist. And we started having, sending ophthalmologists for medical care, ophthalmology medical care. Before we send the ophthalmologist, we make sure they are having Sibahi or all the requirement for Sibahi or whatever, and they should be all privileged. They have Saudi license for health practice, and also they have insurance for medical practice. And it's not only that, we give them a booklet which consists of 15 pages, and there they are supposed to fill all the data. They're like clinic, and maybe Dr. Maisas Williams knows that, and how many patients he saw in the clinic, how many surgery, also laser treatment, all patient, and it's all the information, and we give them the opportunity to evaluate the hospital, to evaluate the facility, to evaluate the cooperation, to evaluate everything, and we communicate with the General Directorate of Health in each region. So we try to improve it on a yearly basis, and with each ophthalmologist, we use to read the evaluation and see if there is any defect. We'll try to overcome the defect. Later, I collect the data with my department, and we published it in Miaju, and you can see here the improvement on the level of ophthalmologists. The number of ophthalmologists was 407 and optometrists 147. And this is just only make a big difference. Now all hospitals, they have the facility, they have the ophthalmologists, they have the optometrists, they have everything. And sometimes they have less productivity. So with all the facility and less productivity, there must be something lacking in between. So we just send a report to the hospital administration with this comment. The facility and everything was at the good shape and good level, but unfortunately, the productivity was not impressive. Then it was taken to the ministry, and this is to Dr. Abdullah Rabi'a, the previous minister, and he was very happy about the suggestion, and you can see his comment, the last two, just only, this is the start for productivity in the ministry and also rewarding. And it's clear in his statement, and he was to implement it not only on ophthalmology, all other departments and other fields. And this is table which show our productivity for our ophthalmologists during visit to the peripheral hospital. It's you can see it here. 116 ophthalmologists were sent over the 6 years, and they saw to 201 and 540 patients, and they did 2,388 surgery over 6. You know, sometimes I have no interest here. Sometimes you might stop the work of all the department, and those who's working in peripheral hospital, they knows what I mean. If they don't have Helon, that means it will stop. So we are working now with the ministry to provide, to have a central store, and to just only provide it to any hospital in the periphery to avoid collapse and of the department. And with Dr. Abdul Aziz, as per his instruction, we are having a future plan now. Just only, as you know, the cataract is the most common and the prevalence of the cataract. So we are preparing now phaco machine with the IOL and other consumables to send it even with our ophthalmologists if there is any, because sometimes when we send our ophthalmologists, they have problem to do surgery because of lack of material. Diabetic retinopathy, we are preparing injection clinic, and it's already started in Ar'ar and also Hafr al-Batin. So it's not just, as you know, keratoconus, it's very common in the kingdom, and also other corneal disease. So we are working to just provide peripheral hospital with corneal tissue and provide other subspecialty glaucoma and pediatric globlastic like Ahmed implant, mitomycin, all these things. And we are cooperating nowadays with the School Health and Ministry of Health. So to make that. We have here a slide, I think Dr. Adil, he wanted me to move. So we are trying to set up now a KPIs for the ministry. So the productivity for each ophthalmologist will be monitored on a monthly basis, and also the optometrist. So this will avoid now outreach and volunteers. Please feel free. We are ready in outreach to help and assist anyone who want to work as a volunteer in any part of the kingdom. We are very pleased to help and to arrange for his visit. So, and that's what's happening with many others. I can mention Dr. Hafid al-Falih, he's going to Jof, and many others. So please feel free. And in conclusion, outreach need high understanding of the whole process from all concerned people, and outreach need continuous support, mainly financial and administrative, to ensure the productivity of the program. And outreach is a unique opportunity to overcome the deficiency which might happen in the peripheral hospitals, and outreach is a very productive way of delivering high standard ophthalmology care and improving ophthalmology services in the peripheral hospital. And also it's an opportunity to get benefit from the graduated and to get benefits from the KKESH facility and training program. Thank you very much.
شكرا دكتور سعيد. The next presentation is given by Dr. Mohammed Al-Saghir. He is the Assistant Deputy Minister for Transformation, Director of Co-Urbanization, Vision Realization Office in the Ministry of Health, Saudi Arabia. His topic will be the national and community engagement under the new transformation of the Ministry of Health. Dr. Al-Saghir. Now we have some problem with the loading, which should be solved. If I may call the second presenter, and he is going to talk to us about engagement of the media, social and non-social media. Dr. Eduardo Mayoraga, okay? Okay. He is the honorary head of the eye department in the Italian Hospital of Buenos Aires, Argentina. Sorry to mispronounce your name. Please, Doctor.
It's difficult to pronounce. It's Eduardo Mayorga. It's the one on tips. No, the one below. I feel more protected like this. Okay. So, good afternoon, everybody. It's a pleasure and an honor to be here today to share with you some ideas. I am an eye surgeon, but mostly I'm a teacher, and my area of interest is e-learning. So when talking about how to reach a community, my community is the community of learners all around the world. So I probably will be focusing on that more than outreaching to other kind of communities. The other things, I got several talks. This one is the shorter one. So I will be probably talking only about 6 big ideas about this outreach. And I will expand more on my following talks. So every hospital, important hospital in the world, has its website where he puts resources that are directed to their potential patients, to doctors outside their country, and community in their country. Also, they want to reach influencers, the government, and probably also the news. And for this, they use different channels. One of them are the newsletter, mostly used for professional relationships, and of course, social media, that plays a very big role nowadays to contact and communicate with your persons of interest. Newsletters are probably the most used to connect with colleagues. And for this, you need to get their names. You need to build a database. You need to build a database not only local, but international. So one thing you need is to collect their names at some point in your website. If you do this, make it easy. Make it easy for them to register using social media like Facebook, Twitter, Google. And if you're going to ask them to register, start asking only for email and password. You can later ask for the rest of the details you're interested, but you already have them in the database with the email. In your website, especially those areas that are teaching interventions, make them available only in a part to anybody without logging in. But especially when you're giving certificates, when you're giving things out that really interest your users, there is where you should request them to log in. YouTube is another social media used especially to show your videos. Remember to separate your channels. One clear channel for patients and general public, and another channel for ophthalmologists. And in these channels also set them up in different playlists to put in order your videos. But do not use YouTube as your main repository for teaching interventions. YouTube is very good to get found, but the value of these continuous videos with no menus, with no interactivity, is much less that you can get putting your teaching interventions in other settings, and I'll talk more about that later or tomorrow. When reaching out to other professionals, start in LinkedIn. LinkedIn is the place to reach out to professionals. It's a place where you can blog and communicate. There is no limit in the words you put in. You can put in videos, you can put in photographs. And once you've done it, then it's very easy to send this through all other social media channels. Tip 5, connect with others. LinkedIn is probably one of the easiest ways to connect with other professionals and collect this database you will need to reach other professionals. And finally, with Twitter, also a very, very powerful tool. Also remember to create completely different accounts for your patients and for the public in general and for your doctors. You will probably want to have in your own language the one that is for your patients or a public, but if you want to reach outside and any doctors around the world, this of course will be in English. So summarizing, create your database, build it over years, and you will be able to reach a lot of professionals. Separate your channels on YouTube or on any social media. Do not use YouTube as your primary repository for your teaching interventions. Start your communications in LinkedIn and then spread it out to the different social media. Try to connect to as many professionals around the world using LinkedIn, and have separate channels also for Twitter. Thank you very much.
Thank you, Dr. Eduardo. Ready? We can have now the presentation of Dr. Mohammed Al-Saghir. Not yet. In this case, can I call the presenters to come on the podium here so we can start the discussion? Dr. Rao, Dr. Eduardo Mutawwa. Once the presentation, Dr. Saghir, once the presentation is ready, we can incorporate it. Now the title of this session was Reaching Out Nationally and Community Engagement. After listening to the presentations we had, if I may open the floor for any question, any comment.
Dr. Adel?
Yes, Dr. Ali Al-Rajhi. You have the microphone, please, Dr. Tfadal.
Do you hear my, okay. My question is to Dr. Saeed. He mentioned that people who are interested in going and providing services in different locations in the kingdom are welcome to do so. So what is the way and how to apply and work on that?
What is the mechanism of volunteering with KKESH?
Yeah, thank you for such question. Actually, KKESH is trying to provide services, not just only through the KKESH, also through all our colleagues. They are welcome. And we started already. I mentioned as example, Dr. Hafid Al-Faleh. He used to visit Al-Jof Hospital just only as a volunteer, and many others. And I'm sure, like Dr. Khalid Al-Jubair and others, they are visiting the hospital in their own arrangement and their own thing. So I think this is time for volunteers to at least help patients, and we are ready to help them to arrange with the hospital to provide all the facility for them.
Do we have, yeah, Dr. Mutawa,
Yes,
do you have in the website or somewhere where we could have some, information about the doctors he can feed and the time that he can give, and then by somebody to synchronize time with specialty with?
In the past, we used the social media, and now under the direction of Dr. Abdulaziz Al-Rajhi, we are planning to make more things organized, so we can involve our colleague in this providing these services. So we are now trying to get it through the website or whatever, and Dr. Abdulaziz Al-Rajhi mainly working in that to improve the things and to make it more organized and more through the hospital organization. So
any idea from our colleagues about incorporating, engaging volunteers? What is the experience?
I didn't get the question.
Your experience about engaging volunteers.
I personally don't have any experience engaging volunteers, but from what I hear from others who engage volunteers, the experience is very varied. Those organizations which have a definite system of volunteers and how they should be functioning, they do well. But those organizations who accept volunteers without a proper system, it doesn't do very well because it varies and there is no regularity of services, and the patient care becomes chaotic because of the non-reliability of the availability of services, because the volunteer may or may not show up at that particular time because of the lack of a system.
Okay.
I have a question.
Before we go to another question, any experience about engaging volunteers?
No, as I told you, my specific area is teaching and not public health.
Okay.
and that.
Okay. Okay. We'll go to your question. Ali Al-Rajhi, please. Dr. Ali.
Dr. Rao, here. This was a major effort in India, though a population of 1 billion. It's extremely good effort. I have one comment regarding all surveys. When they do big surveys, they usually concentrate on methodology of examination by only not slit lamps, but only on torch. And even sometimes they don't go back to examine the retina. And this sometimes leads to underestimation of other causes of blindness and visual loss related to the posterior pole, like optic nerve or retina. Did you find different methodology having different results in any of the surveys?
I think people like Babar Qureshi have more experiences, but I can try and answer that. There is definitely differences with the different types of epidemiologic methodology that we use to do the surveys. For example, the very first study that we did in our institute is a very extensive epidemiologic survey of over 10,000 people, which took over 3 years and very expensive. Whereas now, more and more all over the world, people are doing rapid surveys. Rapid surveys are very valuable to get a baseline and then periodic follow-up of the impact of the services that are provided in the interim, because it's very difficult and expensive to repeat large-scale, detailed epidemiologic surveys. There will be a difference in the estimates between the two types of surveys. There's no question about it. And then also what methodology even within surveys is used. For example, for a long time, people were not looking at presenting visual acuity. They are looking at best corrected visual acuity. Because of that, we missed out on the fact that uncorrected refractive error is a major problem of blindness and the #1 problem of visual impairment. That was missed because nobody was looking at presenting visual acuity. So things like that, for a long time, people, like in our study, the first study that we did, we dilated the pupil, took the fundus pictures, and when we did all that, the earlier feeling that in India 80% of problem was cataract was immediately gone, because then we found out it was not the cataract that was the problem, it was something in the posterior segment that was the main cause. So the number dropped down to about 50% of blindness was due to cataract. So certainly methodologies have an influence on the numbers that we get.
If I can add to Dr. Rao, when you are faced with huge rush of patients, or you are serving a huge community, you have to weigh between practicality and being ideal. And you'll find yourself sometimes that you are pushed to shortcut certain procedures or techniques in order to be practical. Do you agree with me?
Yes and no.
And without compromising the quality.
In our system, we don't compromise. I don't think every ophthalmologist has to do thousands of operations and thousands of patients. And I think our world's problem, in my view, is not using the number of ophthalmologists already available in a proper way. Because there are many ophthalmologists in the world who are used very, very suboptimally. So we have to find a solution of how do we bring patients to them, make them take care of more patients, instead of a few institutions or a few ophthalmologists trying to do a large number, and then the others are doing nothing. In India, for example, where there is a hospital already existing, where there is a good practitioner already there, others go and run eye camps in front of that hospital and in front of that practitioner's clinic. It doesn't make sense to me. So those are the kinds of things that we can avoid. We can overcome a lot of problems of quality. Some simple solutions can eliminate problems of quality.
I have comments on this, because methodology is extremely important to determine the exact cause of blindness. Because if you go with just torch, you might ignore, as you mentioned, any retinal problems or optic nerve related problems. But one of the ways of saving manpower, there are a lot of fundus cameras. They do screening. It can be done by anybody who just gets a very short-term training and non-mydriatic, and they have very wide field, and they can examine without even involving doctors or even experienced people to do it. And this is one way of improving the methodology to get the real causes.
One thing we tried to do was to actually segment the need and develop human resources, competencies to match the needs. Like, for example, in our primary care vision centers, the vision technicians who are trained for a year can perform the tasks that they are supposed to do very well. We had 2 studies that were done on the efficacy of these vision technicians leading to PhDs, and they clearly showed that these vision technicians, when they are well trained, can match 85 to 90% of what an optometrist with a 4-year degree can do. So, for that particular purpose, in a rural area, for screening, they are more than adequate. But don't expect them to be very good in diagnosing every eye disease. We should not have that expectation. When we are very clear about what we are expecting, then we can get the expected outcome.
Thank you, Dr. Rao. Dr. Fernando, you have a... Yeah.
Sorry. Yeah. Now, my question was that a lot of blindness prevention is done through patient education. And probably in urban areas and areas that have cell phone coverage and people have resources to have these phones, this is easily done using this multimedia. But how do you do this in regions where this is not a technology you can use? How do you do this?
In the remote rural areas where people may not be literate or educated, the best approach to educate them is to use the common platforms that exist in villages through various festivals, various kinds of media, television, because each village has at least one central area where there is a television where people gather. And then also transmit the information through various groups that actually go into these villages and participate in various activities. So everything is very local. Each country and each state has its own way of reaching out to people in rural areas. If we could use them effectively, messages can be transmitted. Certainly the social media and all are quite far away from them.
Okay. Dr. Abdelaziz, Dr. Babar. Then,
I think we have to stop because
no, we'll give him the last 10 minutes.
Yeah, he has 15 minutes, his lecture. And we have less than 15 minutes to go.
It's said 10 minutes, isn't it?
My question is to the panel, maybe Dr. Rao. We're going to do a national survey of eye diseases and vision impairment, as well as a study of what's available within the kingdom in terms of resources, human resources and facilities. And one question that came up is whether we do the survey on nationals only or nationals and expats. In other countries, this is probably it's not even a question, because the number of expats is limited. In our country, it's about 1/3 of the population that is expats, and they keep on changing. So if you do the survey only on the nationals, you're not really true information of what is needed and what's the condition in the country. And if you do it on everyone, apart of them from the cost, there is 1/3 that change maybe every 2 years, 3 years, some of them every year. So what would be the best approach to focus only on the nationals, taking into consideration that eye care services are for everyone, not only for nationals, or doing all of them?
I think it depends too, I think in my view, on the policy of the national government. If the government is going to cover everybody in that country, it has to be everybody, whether they are expats or nationals. But if the services are limited to national people and not the expats, then probably it makes sense to do the survey on them. Or probably when you do the overall survey, you could definitely segment the results when you analyze the data and then plan accordingly using the national data for the national plan, and then the expats data for planning for expats. Probably you could segment the analysis of results. That's my view.
Okay, we'll leave the last 15 minutes for Dr. Sghayir. I'm left with 2 minutes now. I may take the question of Dr. Babar.
So actually the question is that currently there's a lot going on mHealth, and a huge amount of work has gone on in outreach and mHealth. I did mention you, Dr. Rao, mentioning the drone slit lamps. We've heard a lot about drone delivery of medicines. How do you see this taking on the future in providing outreach services?
The drone slit lamp that we are using is the technology of robotized slit lamp, developed by Jean-Marie Perel at the Bascom Palmer. Jean-Marie actually transferred the technology to us because he thought that we could use that better. He developed it mainly for US Armed Forces to begin with. And we are able to implement it by one of our senior doctors sitting in the main institute and examining a patient 400, 500 kilometers away, where he puts the chin on the slit lamp. Sitting in Hyderabad, we can examine the patient live. So those are the kinds of things that are possible now. And people are now talking about taking people through surgical steps in remote rural areas by guiding surgeons through robotized approach. That is probably the future. So where it will eventually end, with so much technology revolution is happening at such a rapid pace, sometimes difficult to predict.
I have 1 minute for Dr. Samir.
I have a question regarding cost-effective problem. Now, when you're doing cataract surgery, what do you think about small incision cataract surgery, ECCE, versus phaco, where you need sterilization and more expensive material?
How do you compare cost effectiveness between phaco, small incision, and ECCE?
And again, if you use the same type of intraocular lens, same type of, because there's so many variables in the surgery. It's not just the phaco or the ECCE or small incision. It's the cost of the lens, it's the cost of the viscoelastic and other variables. So if others are all same, certainly the phaco costs more because the consumable cost of the phaco hand pieces and others is more. So certainly it would cost you more.
So will you go for phaco or will you go for small incision so you can cover more numbers with less effective?
For most of the rural care in most places, at least in India, the standard procedure has now become small incision cataract surgery with Indian-made intraocular lenses and viscoelastic substances. That's why cataract surgery in India is the least in the world today, because all locally made consumables are available and the technique used is SICS. And if you look at the literature, the outcomes of long-term outcomes of cataract surgery between the two techniques is not too different.
Thank you. We have to stop now and give the microphone to Dr. Al-Saghir for his presentation.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon. It's great to hear to the panel discussion, but before I start with my briefing about the health transformation in the kingdom, I would like to congratulate KKESH for 35 years of serving the community. It's something that the community is proud of, as will all of us in the medical field. We feel proud of this institution. The service is being developed, and what was done and accomplished in the eye care is cannot be estimated in any kind of words. But taking what the experience from India here talking about is that today the medical knowledge is very significant in the medical field, either in eye care or in other fields. But this medical knowledge does not reach to the patients and does not give access to all of the patient in a very equal way. We still do not have equity and equality in providing care to the citizens and to the individuals in general in any country in the world. If you look at globally, Today, the spending of healthcare is around $7.9 trillion across the globe. And there is estimate that only 60% of that fund goes to the individuals and to the citizens in any country, in India or in China or in US or in Canada. So there is that missing 30 or 40% does not go for citizens and does not go for preventing care, is the lack of the value of utilization. In order to shift to maximum utilization of that fund, we need to re-engineer and redesign the way how we deliver care. Similar to the example just you heard now from India, is how you can reach to different communities, how you can change your approach of giving the care is going to be the future to maximize the efficiency. And that's what the country here is doing today. The country today, we have a Ministry of Health that provide care, and in the same time, Ministry of Health regulate, and Ministry of Health pay. Those three conflicted jobs prevent the Ministry of Health to be advocate for the citizens, prevent all of us of getting the citizen and the individual, the human, to be in the center of our system. And this is why today the bureaucracy and the hospitals and the professionals are the one who's sitting and designing the care today. It's not the citizen, it's not the individual. How we can make that shift to reach to the patient where they are, to get our physicians to serve all of the patients in a very equal way, that's the question we need to get to by splitting these three functions as the first functions. The second thing, we are today in the kingdom, we have 60% of our society are younger than 40 years of age. So our baby boomers are going to come in 15 years down the road, and this is where the cost will expand. So today we have a major platform that is burning because of the chronic disease. We are expected by 2030 to have 8 million. There is a spiral cost. Our healthcare increased by 7% every year. There is a lifestyle that is becoming very dominant of sedentary life, smoking, and other habits in our population and our community. So that will push and premature death. And premature death that is happening in our society today. 46% of our death is premature. This is equal to Egypt and high above the benchmark, which is 18%. 18% premature death. So the kingdom decided to go for splitting of those functions based on the Vision 2030, gave us a KPI that the expected survival is going to be 80 years by 2030. And the citizens, they are going to live up to 80 with a good health. It's not in a poor shape of health. And to shift the lifestyle in the community. So the government came with 7 programs to do this. The first program is to design a new way of delivering care, and that's what's called a model of care, which is basically types of services that need to serve the citizens, and those services will be given to a payer to pay for, and then will be given to a corporates that deliver those services. And KKESH worked with us to develop a model of care for KKESH, which is start from upstream, preventing eye diseases, all the way until tertiary, quaternary, and going back to the community. And that pathway is going to be corporatized through a specialized eye care, and then going to be design payment for that particular services based on the need of the citizens. And then you will need to have the private sector participation with the third sector. So these pathways or these services not only going to be provided by public, but also you need a third sector and you need the private sector to participate, because some of the services, they could do it even better than the public service. And then there is a new workforce. The same experience in India, that not all of the physicians are utilized. The same thing happened in Saudi. Not all the physicians are utilized. There is a shortage of maybe some of the functions of the eye care. And then a new digital health will emerge. A new digital health that will not be only based on EMR, but based on a personal health record, based on the mobile, based on education remotely, and so on. And then governance. a new regulation, and that's the role of Minister of Health. The Minister of Health will only be enabler to create the right laws and the right policies to support the delivery and to activate the citizens to become actively participating in their care. It's not only going to be driven by the organizations. So His Excellency last year, a year from now, he launched the new blueprint for those services that need to be implemented in the country. And there is very large number of, this is how it's look like, these blueprints. There is 400 physicians and patients and NGOs and private sector participate in this design. And there is 60,000 patients were surveyed. There is a large number of physicians and healthcare workers were surveyed remotely and in physical presence. And this is how it look like. There is 6 kind of care settings that today, some of them, they don't exist. Today we have primary care and hospital care, but we don't have the other care settings that need to go. These care settings are, first, a citizen that is activated. So start with the self-care, and that's at home. And then you have the community services, virtual care, primary care, hospital care, and tertiary care. So one of the care settings is the hospitals, but it's not the main one. And then you manage systems of care across this continuum of care. That's Keep Me Well, which is prevention, chronic disease, planned elective like the cataract surgery, end of life, and urgent care, and safe birth. So it's 6 new care settings and 6 pathways or system of care of continuum that manage the patient. And all of this need to be done at a catchment area of 1 million, except some national services. And this is how it's look like. So in the catchment area of 1 million, you apply those services that coming vertically here, which is Keep Me Well, planned care, safe birth, urgent care, chronic disease, and last phase. And eye care will be found in each one of those. There is a preventive programs that could be applied. There is also a plan for the long waiting list. There is a neonatal care, eye care. There is also urgent care for those patients. There is patient with a chronic disease like diabetes, hypertension, and other neurological diseases, and maybe some of the patients who need eye care at their end of life. And the above are the interventions or services need to be provided nationwide for all of the providers. So 1 million catchment area, they will have all these services here down, and there's a detail and design for those services. So this is how it's look like. At the end, we'll have 20 catchment areas between 1 million to 2 million in each, and these are the services need to be there. The patient is in the center, the home is in the center, and then you have the community services around it, and then the primary care and other services, prevention and so on. And the last thing you have is the hospital care, but that's not enough. This is need to be all integrated with the private sector and them and with the third sector, and the patient should not feel the difference. Wherever he needs the service, he needs to get it. There should be no duplication, no excess capacity. If a service exists, there is no need to duplicate it and so on. So this is after we identify these business models, then all the government today providers, they are going to be turned out into be a network of primary care and hospital care, and those going to be corporatized. They are going to become legally not anymore bureaucratic. They are going to become more corporates, and basically they are going to work in creating efficiency the system, utilize their budgets better, they come with better processes. And these are some of the challenges that today we are facing in the system. It's hoping that if you corporatize the system and you create autonomy and allow the departments and allow frontliners to own and to manage their budget and their resources, you'll end it by more autonomous system that can provide these services. So this is how it look like. Today, we have Ministry of Health here with the Regional Health Directorate and Medical Cities, include KKESH. Tomorrow, we will have accountable care organization, catchment area 20, but the specialized care might be in those accountable care or might be separate. It depends on how the specialized care will be designed and how the service will be provided sharely among all the new entities that will come out. So these are the journeys that we are expected to do. We are going to move from today, 2018, all the way until 2030. And it's going to go through phases. The first phase is building the capabilities in the new way of delivering care, a new way where we integrate care, a new way where we get primary care and hospital care and different segments of care to work as one unit. And that building capability will take up to the end of 2020. By that time, we are hoping that every entity will be ready to take out their budgets and to work autonomous and move toward fully corporatizing their entities. And then finally, they will be able to provide the value-based. In this journey, it's expected that the cost will be fixed. There is going to be transparency in the data. There is going to be a new payer, and there is going to be a new regulator. And at the end, as you can see that in the end, you will have a provider that they compete among each other. And you have a payers, public and private, they are going to compete. And there's going to be transparency. And the regulator who's outside from providing the care to allow fair competition and to allow transparency and to allow the citizen to be able to have a choice to whom the citizens should go, and the payer who could pay to both public and private sector.
Dr. Mohammed, we have 1 minute, please.
So this is how it's look at the end of 2030, and I think this is a very important slide. We are going to shift to a value-based center where we utilize our efficiency to the maximum, and there's going to be cost of control and going to be transparency and the better outcomes. And we are going to be patient-centric. We are going to design our services, activate the citizen to participate, giving the citizen choice, and we able to focus in the community and prevention services. That on one side of the system. The other side, the roles becoming very clear. The Ministry of Health will regulate the sector, will decide on the total budget envelope, will assure cost and quality measures and standards. The public insurers or the payer will ensure accountability of purchasing services, al-khadamat, and make the providers accountable for providing the service with the best outcome to keep people healthy. And you have an organization that's accountable for prevention, accountable to keep people healthy, and invest in awareness and prevention and receive the payment. And above all of all, we'll have pathways of continuum of care from upstream, downstream, where the frontliners will be integrated as one team and they innovate and make the service better as we go, and we can reach the rural areas, the urban areas, and we reach, give equity and social fairness to all. And that's all what I want to say, and I would like to thank all of you, Dr. Abdulaziz and the team at KKESH, and I'm pleased to be part of this panel. Thank you so
Dr.
much.
Mohammed. We have 2 minutes for question to Dr. Saghir. 2 minutes. One question from Dr. Waleed.
Thank you, Dr. Saghir, for a very interesting presentation. What's not clear really the role of private hospitals in this new innovative idea, because the questions has two faults. First, is this competing with a private hospital or building on what is there? Also, if the patient is treated on a capitation basis inside the corporation, will be treated also on a capitation basis with a private hospital, or it will be treated on a billing basis?
Thank you so much. I think this is a very important question. There is some of the questions that we know for sure today, and there is some of question probably we'll know by early 2019 and then by 2020. What we know today, that these accountable care organizations or catchments, some of them will be operated by private sector. We know that. We know that the private sector will participate to operate some of these clusters. That's one thing. Second, we know that some of the public provider, we know there are some services, it's better for the patient and for the citizens to be outsourced to the private sector. Because the private sector could do them better, could provide a better quality, could provide it at a lower cost, and could do large volume of them. What is the system we want to move away from? We want to move away from not focusing and keeping people healthy and doing unnecessary medical activities, unnecessary procedures, unnecessary subscription. So if you look today at the public system, it is not efficient. The activity of physician in public sector is 60% below the private sector. But in the same time, the private sector is not effective. How the Ministry of Health today, when they become a regulator, how they can create a system where they become equal. And if you ask Ministry of Health today, they want tomorrow to have 50% share of the market among all of them. And they want to push that direction. But today we are not ready to do that. Today we have a public sector that is based on bureaucracy and lack of efficiency. And we spend at least 20% above what's needed. And we have a private sector that focus on fee-for-service and focus on services that does not include prevention and so on. The way to do that is to design a pathway in each catchment area, and the private sector could fill some of the gaps that can do better, and the public serve the others, and then they can be integrated, and the payer should pay for both. But this will not reach it today. Probably will need 5 to 6 years. يعني يمكن سمعتوا صريح مع الوزير, probably this will need 5 to 6 years, لأنه this split between provider or regulator or payer, it's a very difficult split. It's not easy. And to come with the model which is reached today, it took us 2 years, but we are thinking the pilots that will come in the next 2 years will learn a lot, and there is more and more long-term contract will come from private sector. So I think there's more work to be done to assure that. But the aim is to have the private sector to own significant share.
Thank you, Dr. Mohammed. Now it's time to break, and we will reconvene.
There's a question there.
Sorry, time is up.
Okay.
Maybe we take it in the second session. The next session is going to start 3:15, and the chairman is Dr. Abdulaziz Al-Rajhi. So you have to be in time. Huh?